Wonderful. Thanks, Rachel. I hope everyone can hear me. I am in Boston right now, and I am sure your weather in South Carolina is much better than ours right now. So we're going to jump right into something called, my talk is called Family Building Beyond the Binary. And as Rachel said, I had really a great, I would say, time in my career to be part of Fenway Health, which is a federally funded healthcare center that really focused on building and providing care for the LGBTQ community. It was founded back in the 70s on taking on the HIV community, actually, and it has now grown into taking care of the LGBTQ and BIPOC community. And then currently back with Beth Israel, which is an academic center. But again, I get to do what I love doing, which is taking care of women and people who have a uterus and really fostering healthcare for people who have a uterus throughout their life. So it's been great. I am a content advisor for Walter Kluwer's, and any discussion of testosterone use for people who have a uterus is considered off-label use. Any discussion about estrogen for patients who are sperm producing is also considered off-label use. So just wanted to let you know. The learning objectives today that we'll try to get through very quickly are going to be acknowledge barriers to reproductive health care for the LGBTQ persons, incorporate practices that you can use to promote affirming reproductive care for your patients, and understanding the impact of gender affirming therapies on reproductive health care in general. So let's start with a case that involves a not so typical, but someone that you may see in the future. So this is a gender diverse married couple who are interested in building their own family. So a 31-year-old trans man and a 21-year-old non-binary partner. And when I say non-binary, we'll get into definitions, but AFAB, so AFAB stands for assigned female at birth. Between the two partners, there are no gender affirming surgeries. The trans man is no longer on testosterone therapy and identifies that he would like to carry the pregnancy. And they would like to know what their reproductive options are. Next slide. The medical history of the trans man, you can see, I know it's a lot, but we'll quickly go through it. So the trans man is currently on Zoloft for depression. In the medical record, it says that he has a hormone disorder. He has been on testosterone for many years. He is off testosterone and currently has return of monthly bleeding. His BMI is 33, and his doctor has been discussing starting Wegovy. No surgeries and has no future surgeries planned. He did start cyclical bleeding at age 12, has now, like I said, return of monthly bleeding. No history of abnormal pap smears, up to date on cervical cancer screening, no history of infections, and has never been pregnant. Sexually active, but no vaginal penetration. Is well supported socially, has a job, family is supportive, and has no outside partners. Next, and in his families, there's no chromosomal abnormalities. So in general, when we're talking about family building in this type of couple, there are a lot of resources out there, not just attending this wonderful, lunchtime meeting, but there are things that out there where you can access. Given that there may be limited access in the future, I would say the Endocrine Society has excellent guidelines. The World Professional Association of Transgender Health, WPATH, has the standards of care. The eighth version has excellent guidelines. The American College of OBGYN also has guidelines. And then this is the UCSF Center of Excellence on Transgender Health. That's an old screenshot, actually has excellent guidelines and actually up to date has excellent information. So those things I think are always going to be around and are continuously updated. So even if you forget anything about today, there are still going to be resources where you can learn how to take care of patients who may identify both binary and non-binary, you can learn how to take care of patients. Okay, next slide. So back in 2015, this was an online survey. 2015, the U.S. Transgender Survey. It was very, very big study. So they had 27,000 respondents, and the four big take-home messages from this online survey were that patients who identified as transgender felt there was a pervasive mistreatment and violence that patients felt they were they received. Patients or persons also were living in severe economic hardship, identifying living in poverty. There were harmful effects both physically on their mental health, and that transgender people of color, specifically African American transgender women, experienced deeper and broader discrimination. The harmful effects on physical and mental health. Patients who are persons who identified as transgender had suicide rates 9 times higher than non-transgender patients. And patients, I keep saying patients, I apologize, persons also lived with HIV at 5 times the higher rates than, again, non-transgender patients. Next slide. I think there's and so this survey was then updated. It was a little bit delayed because of COVID. So this was repeated. And in 2022, it was again an online survey, and they had 93,000 respondents. And they actually had respondents, and they dropped the age of qualifications, and it was persons over the age of 16. And they had about a third of respondents were identified as non-binary, a third as trans women, and a third of trans men. And again, you see that a third identified as saying they were experiencing living in poverty. About a quarter did not see a doctor due to fear of mistreatment. And then almost a half, again, had serious psychological distress within the past month. And about a half, again, had a negative experience because of how they identify. One of the more encouraging things, though, is that many of the persons were more satisfied since transitioning to their gender identity. They felt more satisfied since receiving hormonal treatment or gender affirming surgery. So this survey has not come out yet with their final insights. So we are seeing that gender affirming hormone therapy, gender affirming surgical treatment does allow patients and persons to feel better, that they are feeling and living in a much more confident way, and it overall helps their lived experience. Next slide. So going back to definitions, again, understanding when we use this language, what it means. So gender identity is that internal or the inner sense of how you see yourself, whether it's binary, when we talk about two sexes, so male or female, or how you see yourself, or a trans man or a trans woman. So again, you're only seeing two choices, okay? Or you think of a non-binary, so anything else. So you may see language that says gender queer, gender fluid, meaning that sometimes it's somewhere in between. Some people say gender fabulous. Or again, this kind of other, where it's neither nor, and that is how you identify. And then you have gender expression, and then how you affirm your gender. So gender expression is that outward manner, how you affirm your gender identity. And gender expression, again, can be masculine, feminine, somewhere in between. It's how you dress, the manner, your tone of your voice. And then it also can be how you socially affirm yourself. It's your chosen name, it's your preferred pronoun. Medically, it's how you use hormones to appear. It is the surgery you use to modify your body. And then legally, your driver's license, your name on your insurance, or even your passport or your birth certificate. Okay, so that's affirming. And then sexual identity and orientation, again, is very different than gender identity, gender affirmation, or gender expression. Sexual identity is the binary sex that you're assigned at birth. So when we talk assigned female at birth or assigned male at birth, you may see that in the electronic medical record as AFAB or AMAB. So that is a sexual identity is the binary sex assigned at birth based on external genitalia and or the chromosomal identification that a lot of patients will have just with the testing that is available prenatally. Sexual orientation is who you're attracted to, sexually, emotionally, physical. Okay, so that again is very different than gender identity, gender expression. It is who you are sexually attracted to. Next slide. And then gender dysphoria. This is a DSM-5 diagnosis. Gender dysphoria is distressful, and that's where it is. Gender dysphoria is that distress or the discomfort that's caused by the discrepancy between your sexual identity and the gender identity that you feel. What you see in red or pink is the ICD, the old ICD codes. And you can see that the language itself is kind of unusual, you could say, although again, we're going to see that language changes. This ICD-11, gender incongruence, is what is going to be used to talk about how we code these things. And like if you go back to our first case, we're talking about how um, under sometimes it's hard to decide like how do we code this when you see someone. You could see hormone disorder, gender identity disorders, but hopefully soon we're going to be seeing gender incongruence. But not every transgender person has gender dysphoria. It doesn't cause them distress. But gender dysphoria can be when there is when there is distress, discomfort, and they seek care. Sorry about that. Next slide. And so what can we do what can you do? What can offices do to provide this inclusive reproductive care or to provide inclusive care so that we don't add to this dysphoria and that we can provide respectful care? So look around your office next time. Look around when you go to any office or any type of workplace and see what type of signage there is. What we can do is provide non-gendered language on all decor, on all signage. Look at intake forms and consent forms and see if we've degendered the language. You think about IUD consent forms, about surgical consent forms, and look if it says he or she. Obstetrics and gynecology has societally always been a cisgendered department or services. And so you think about even on OB consent forms, it usually will say mother, and think about degendering that and changing language to be much more inclusive. Making sure that your staff has had advocacy education and making sure that they are able to also address persons correctly. Updating the EMR, I think, is incredibly important. And knowing how to use your EMR and your notes, your medical notes correctly so that you can convey correctly into other providers. Epic has great ways of using organ inventory as well as banners that say chosen name or preferred pronouns. And then also having in your toolbox multidisciplinary networking, knowing who is trans friendly or having referrals that you know providers who are trans friendly and know how to have intake forms and address patients correctly. I like this poster. This is from Family Health that was produced by the Trans Health Program. They had it in all of the rooms, and it was just simple, something that just said pronouns are vital. And for a couple of months, we would have at the front desk either stickers or pins that patients could choose from and just put on their on their shirts that just said their pronouns. And it just really underscores that clothing, name, hairstyles don't always tell us about a person's gender identity or pronouns. And it was a really successful campaign, something that, you don't have to be at Fenway to do, to understand that it does sometimes shows inclusivity, but also shows respect and safety. And so terminology, I do think, is a great way to show that you understand patients, that you are being providing a safe and understanding environment. But terminology is changing, correct? And even now, I think we're evolving and finding new language. And in about 5 minutes, we can, and what I would love for everybody to be able to tell me other ways that we can address people. So we'll take a quick look at this, but you can see that there are ways to replace wording. Next paragraph or next slide. And so WPATH, again, they have come up with great guidelines, understanding that all humans and transgender individuals have reproductive rights, whether or not to have children, but then also identifying that medically necessary gender affirming hormonal and surgical interventions do truly alter reproductive anatomy and limit future reproductive options. Next slide. And they came up with 7 really important, I think, bullet points to keep in mind. And really, it all comes down to making sure that we take care of patients and we, on a regular basis, ask patients about their future pregnancy intentions and asking about reproductive, what type of sex and their reproductive intentions. Next paragraph or next slide, sorry. This is an old snippet from UCSF, but just keeping in mind that infertility is not an absolute or universal notion in transgender people undergoing hormone therapy, and also underscoring that gender-affirming hormone therapy alone is not a reliable form of contraception, which we will be talking about in 2 weeks. And that testosterone is a teratogen that's contraindicated in pregnancy. Next paragraph. And also underscoring, I know we're focusing on prenatal care, but also remembering, just like with all patients who present to OBGYN and talking about prenatal care, that preventative health care and primary care, just like all persons, is important. But one thing to keep in mind is that if anatomy is there, we need to check it. So not making assumptions that if we're not using that anatomy, that it doesn't matter. So again, clinical care is based on up-to-date anatomical inventory. If there's breast, chest, vagina, cervix, ovaries, uterus, it needs to be checked, okay? Even if someone says, I'm planning on getting a top surgery, I'm not going to be, my risk for cervical cancer, I don't even have penis and vagina sex. It needs to be checked. Next slide. And again, this is adapted from Up-to-Date. It's a great resource to look at what, even for trans men and trans women, what needs to be checked. I will say that it is a good resource. And remember, again, it all comes down to anatomy. If the tissue or the organ is there, even if it's not being used, needs to be checked. Next slide. And just a little note on cancer screening. So limited studies on cancer risk for transgender persons, simply because many of our cancer documents have never don't really include, don't ask patients to identify their sex or their gender identity. Gender-affirming hormone therapy does not increase risk of cancer. However, it does increase the risk of not being screened simply because of provider or patients not going to the doctor when they need it, or providers not making assumptions, right? So gender-affirming hormone therapy does not eliminate potential cancer risk in natal organs. And that established cancer screening guidelines for cisgender persons can be applied to transgender persons as well. And just medical mindfulness, again, when we're talking about general exams, listen and incorporate everybody and how they describe their own body parts, individualize how you approach everyone, and please be thoughtful about everyone's past trauma experience Avoid making assumptions about sexual orientation, sexual practice, and definitely document organ inventory and continue natal sex surveillance. Next slide. And again, same thing. Be very, very specific in what you're going to do, and how you're going to touch patients. Um, Next slide, we're going to kind of, actually, Rachel, maybe we're at 20 minutes. Let's take a quick pause